All right, we are going to talk about diabetes and the drugs to treat diabetes. Excuse me. So first we're going to start with just talking about some generalities about diabetes, looking at the symptoms of insulin deficiency and distinguish between the two primary types. I'm sure you all know there's two types of diabetes. Historically, we refer to as type 1 as being type 1 or juvenile onset, or probably the most appropriate way to refer to this would be insulin dependent, because they need insulin, they don't make insulin. Or type 2 historically has been referred to as adult onset, or probably most specifically non-insulin dependent diabetes. So diabetes is a disease of blood sugar regulation. So there's dysregulation of blood sugar. So I'm sure you remember there are two hormones produced by the pancreas that are responsible for, not solely, but responsible for maintaining blood glucose. One is insulin, and insulin is released when blood glucose levels are high. So after a meal, for example, insulin is released from the beta cells of the pancreas, and insulin then binds an insulin receptor, which causes glucose transporter channels to be inserted in the cell wall, and glucose then can travel from outside of the cell or from the blood into the cell. So you see on the slide there that cells take up glucose from the blood under the influence of insulin. Any excess sugar in the blood then can go to the liver, and the liver can produce glycogen. Glycogen is just basically a large, many glucose molecules linked together. So the key here is that in response to the release of insulin, blood sugar should fall. When blood sugar is low, the pancreas releases glucagon. Another hormone comes from the alpha cells of the pancreas, and what glucagon does is it causes the liver to break down stored glycogen, among other things, and it causes blood glucose levels to rise. So the ability to maintain stable serum glucose level depends on the ability to store glucose in times of excess and return it to the blood in times of deficiency. So there's a range in which glucose is maintained, and that is dictated by insulin levels and glucagon levels. Blood sugar should never get really high if insulin is present, and it shouldn't get too low if glucagon is present. So you can kind of see here as the blood glucose levels rise, you eat a carbohydrate or anything, but carbohydrates are a good way to get blood glucose up. Blood glucose level starts to rise, the beta cells of the pancreas release insulin, and that causes the glucose to move into the cells, so blood glucose starts coming down. Excess glucose would be stored in the form of glycogen. As blood glucose levels fall, like with a sustained fast, then the alpha cells are going to release glucagon, which is going to then cause the glycogen to get released, and the blood glucose levels will then rise. So here is a comparison. This isn't really a pathology class, so we don't need to go into a whole bunch of detail, but I wanted to give you this so you have it for your records. We're still referring to these as type 1 and type 2, although I would prefer, if you remember, type 1 as insulin dependent and type 2 as non-insulin dependent. Just makes more sense. So type 1, insulin dependent, is because they lose the beta cells. So they essentially lose the capacity to secrete insulin. And that can happen early in life. It can also happen later in life. It doesn't have to be juvenile onset. Type 2, they're insulin resistant. So they have plenty of insulin, and in many cases, actually, they have high levels of insulin prior to the diagnosis of diabetes type 2 or non-insulin dependent diabetes. The reason why we call it non-insulin dependent is because they have insulin. That's not their issue. It's an insulin resistance. Their cells lose the sensitivity to insulin, and we don't know why. Over time, they could become insulin deficient, but that doesn't usually happen till later on. You can see it's much more common. This non-insulin dependent diabetes is much more common. Between 90 to 95% of diabetics are non-insulin dependent. 5 to 10% are insulin dependent. Historically, younger people are diagnosed with insulin dependent. Like I said, that can change. Historically, people older than 30 are diagnosed with a non-insulin dependent, but that can change as well. The symptoms usually come on really fast with this one because they actually lose their capacity to secrete insulin. So all of a sudden their blood sugar goes out of control. Whereas with this one over here, it's a lot slower. It's a gradual, slowly they climb up until they reach the level at which the diagnosis of diabetes is made. People with insulin-dependent diabetes tend to be underweight because they cannot get sugar into their cells, right? Whereas the non-insulin dependent people tend to be overweight or obese. We think of this more as a lifestyle issue. Very definitely the symptoms for insulin-dependent diabetes: polyuria, meaning they're urinating a lot; polydipsia, they're drinking a lot; polyphagia, they're eating a lot, and they're losing weight. So these two don't tend to go together. And the reason why they're eating all the time is because they're trying to get some sugar into their cells and they can't. The same symptoms are present with type 2. Plus, as it progresses even more, they get visual disturbances, a lot more fatigue, and recurrent infections because they've got so much sugar running around in their blood. Ketosis is quite common in people with uncontrolled insulin-dependent diabetes. Ketosis is when ketone bodies start to increase in the blood, and it leads them into what we would refer to as ketoacidosis. And the reason why they have so many ketones is because they cannot use carbs for fuel, so they have to break down other stuff. So a byproduct of fat and protein degradation, but specifically fat, are ketone bodies. And so they have a lot of ketones in their urine, and they have a lot of ketones in their blood, and their blood pH tends to be more on the acidic side. That's not quite as common with type 2. It's possible, but not quite as common. This is what you want to remember because this is pharmacology. People with type 1 diabetes or insulin-dependent diabetes, they need insulin, period. And I'll show you, running you through some versions of what kind of insulin. People with non-insulin dependent diabetes usually are started with an oral agent, of which there's quite a few types. We'll go over them. And maybe at some point they might need insulin, but they don't traditionally start the non-insulin dependent diabetics on insulin. All right, so we've already talked about this, but here's a little summary. Insulin, what insulin does is it increases the transport of glucose into the cells and also the synthesis of glycogen, which is just stored glucose, and glycogen is stored in the liver. It increases amino acid transport into the cell, increasing the synthesis of protein. It increases fatty acids into the cell, increasing the synthesis of fat. All of those are what insulin does. So diabetes is especially insulin-dependent diabetes is a disease of insulin deficiency. When you don't have insulin, your sugar stays in the blood, right? You need insulin to get your sugar into your cells. So they have hyperglycemia, which means high blood glucose. They're thirsty, they're urinating a lot, and they're dehydrated. And the reason why they're urinating a lot is because there's a huge amount of sugar in their blood, which filters freely at the glomerulus, and it's a solute, so of course it's going to osmotically pull water with it, and there's no place to, well, that's not true. We normally, under normal circumstances, if you have the right amount of glucose in your blood, we reabsorb 100% of that in the proximal tubule. We talked about that last unit. But if you're loaded up with glucose, you can't absorb all of that because it's moving through the tube, and so the rest of it stays in the tube. Once you pass the proximal tubule, there's no site at which glucose can be reabsorbed back into the body. So the glucose and the water stay in the renal tubules, making them pee a lot, making them potentially dehydrated and also quite thirsty as a result. Ketoacidosis is what we just discussed. Ketoacidosis, when somebody actually is experiencing ketoacidosis, they have a symptom that oftentimes gets referred to as fruity breath. And also they're really hungry. Fruity breath is not as nice as it sounds, right? It's not like orange blossoms. It's like the orange that you lost in the corner of your refrigerator, 3 weeks ago. It's like the fruity, meaning like rotten fermenting fruit. That's the kind of fruity breath. Once you smell it, you can't ever unsmell it. You'll always know the smell. So that's common with insulin deficiency. They can fall into a coma as a result of either the dehydration or the acidosis or both. They get a lot of vascular damage in both cases with either type 1 and type 2 diabetes. And their eyes are damaged, their heart is damaged, and their extremities are damaged. The heart gets damaged most effectively because the actual vasculature gets damaged. We get a lot of damage to the endothelium, which makes the vessels more rigid, which makes the heart have to work harder. So the heart is more prone to heart failure secondary to the vascular damage. The eyes get damaged because the eyes are actually one of the locations where sugar can move into the cells without the assistance of insulin. And so because there's so much sugar in the blood, and you don't need the insulin to get the sugar into the part of your eye, the sugar just floods it along with the water. So it just basically kind of blows them out. So they got a lot of swelling. I'll show you a picture of that in a minute. A lot of increased blood pressure in the vessels in the eyes. And then their impaired fat metabolism also tends to affect atherosclerosis. They break down a lot of fats. They're not as effective at transporting fats into the cells, so they get that fat oftentimes gets munched up by the macrophages that are found in the endothelium and incorporated into the plaquing. So you get more atherosclerosis as a result. So here's your alpha cells and your beta cells. We said it already, but the beta cells secrete insulin. Insulin lowers blood sugar. Alpha cells secrete glucagon. Glucagon raises blood sugar. These are found kind of towards the pancreatic tail in those clusters of cells we like to refer to as the islands of Langerhans. This is some of the vascular damage you can get with diabetes. So they get a lot of, so this is a blood vessel, right? It's supposed to be a nice open tube. It's not looking so good. And this is as it gets way more complex and more plugged, right? This is actually a clot completely occluding that tube. So very, very common with diabetics to have a lot of vascular damage. These are the microaneurysms in the eye. So if you were to look in with your fundoscope, you'd see all these little micro bleeds. You'd lose, so here you lose the ability to track these vessels, and as it gets much worse here, this is a huge hemorrhage in the eye. Also, they're a lot more prone to cataracts. You can see that there, so that's very common. This is an actual eye. These are all little bleeds in the eyes, microaneurysms in the eyes. This is the retinopathy. This is a lot of scar tissue in the eye, which is common. You get a lot of kidney damage. And it's due to a couple of things, but one of the main things is there's so much sugar in the cells that they're a lot more prone to infection. So that's what's happening here. This is what they refer to as necrotizing papillitis. So this is all pussy lesions in the papilla of the kidney. So when that happens, they have acute renal pain and they start urinating blood, which you can see there. Urinating blood is never a normal finding. Because of the vascular damage, because of the fact that there's so much fluid in their blood vessels and so much sugar, they're prone to a lot of edema. Their glomerulus starts to get really, the spaces between the glomerulus tend to start to get stretched out, which causes them to filter things they normally would not filter, like protein. And so you're seeing here albumin in their urine. That protein tends to kind of get stuck in the renal tubules, and it looks like these waxy casts. They are also, they get a lot of nerve damage, neuropathy. I think I'll have a slide of that in a minute. But their circulation, because of the vascular damage, their circulation tends to be bad and their nerves tend to be bad. And so they have an increased risk of wounds that won't heal. And that's what you're seeing here, right? This is the beginning of a diabetic foot ulcers that oftentimes can get gangrenous, right? They just don't have enough circulation, and they have a lot of sugar in their blood as well, which feeds any infection that might be present. That's an actual diabetic foot ulcer. That's another one. It's hard to imagine that these things can get like this, but you have to remember they can't, first of all, they're very slow to heal, really poor wound healing, and they can't feel that in many cases because they have really very little sensation because of the neuropathy. So other things that we see with neuropathy, they lose vibrational sense. That happens really early. It's something we want to test all the time. Ankle drop, wrist drop, oftentimes their ocular muscles will become paralyzed, so their eyelids kind of droop. The neuropathy can look like increased sensitivity to pain, or hardly any sensitivity to pain, not able to feel much of anything. Their joints oftentimes swell, especially when they're losing a lot of protein. We talked about the gangrenous foot ulcers before. Okay, that's enough for that. So let's talk about some numbers really quick. So diabetes mellitus, as of pretty recent data, we know that there's more than 20 million diagnosed diabetics in the United States. There are probably a lot more than that running around. 29 million really have the disease. It's the 6th leading cause of death, counting only the 200,000 per year that list it as a cause of death. You have to keep in mind that this increases your risk of all cardiovascular diseases. So many people that die of cardiovascular disease, heart attack, strokes, etc., heart failure, really have diabetes, but they're not going to list that on the death certificate. So it's really hard to kind of tease out that number. I mentioned the two main types: insulin-dependent diabetes, historically referred to as type 1. Those people have identified insulin deficiency. Non-insulin dependent type diabetic, historically referred to as type 2, they do produce insulin, in many cases lots of insulin. Actually, their insulin levels tend to be high if you're monitoring that prior to the advent of the disease, before the blood glucose gets too out of control. So here again, this is the type 1 or insulin-dependent diabetes mellitus, lack of insulin. Not all that many, about 5 to 10%. This disease is considered autoimmune largely. It seems like there's like this perfect storm between autoimmune, genetic, and environmental factors, which we know autoimmune diseases are oftentimes driven by both the genetic and environmental factors. So there's usually some sort of genetic susceptibility and then some sort of insult, which is what causes the autoimmune destruction of the beta cells of the pancreas. Oftentimes it will follow some sort of viral illness or some kind of chronic infection as well. Historically, we see it in younger people, but it can happen at any age. And the big issue here is glucose can't enter the cells. So therefore we have to switch. Proteins and fats have some issue getting into the cells, or the byproducts of protein and fat degradation, but not as big of a problem as glucose. So the metabolic byproducts of lipid metabolism, which are the ketones, start to accumulate in the blood, and that's what leads to diabetic ketoacidosis. This is what you want to remember. All patients with insulin-dependent diabetes mellitus must receive insulin therapy. Type 2, or maturity onset, or more appropriately referred to as non-insulin dependent diabetes mellitus. Way more common, about 90 to 95% of the patients with diabetes have this kind. They're going to present with hyperglycemia, characterized by what we call insulin resistance. So essentially what's happening is the cells are becoming unresponsive to insulin because the insulin receptor loses its sensitivity to the glucose. As I said earlier, it's often characterized by a surge, an increase in insulin, but it can over time burn out those beta cells where they'll actually stop producing insulin, but that's down the road. Historically, the symptoms show up after 35 or 40 years old, but that's changing. Obesity is very common. This is the one we consider a lifestyle disease. Non-insulin dependent diabetes risk factors for non-insulin dependent diabetes are a positive family history of insulin or of diabetes. African Americans, Native Americans, Hispanic Americans, Asian Americans, and Pacific Islanders are all at higher risk, so race is an issue. Obesity is an issue. Other things that we kind of want to watch are people, their risk factors go up as they increase in age. I think that has more to do with lifestyle than it does with just age. If they have a history of elevated blood glucose or impaired glucose tolerance, including if that happens when they're pregnant, or if another thing that's important to note is if you were born of a mother who had gestational diabetes, then you are also at higher risk. So the history of if your mom had gestational diabetes, the baby is at higher risk for diabetes as well. Hypertension, low high-density lipoproteins, triglycerides that are greater than 250 milligrams per deciliter. And the other thing, which is usually a sign of gestational diabetes, is the delivery of a baby over 9 pounds. If you were greater than 9 pounds at birth, your risk for diabetes goes up pretty significantly. Most people with non-insulin dependent diabetes do not require insulin. Instead, they're going to be started with oral agents. Later on down the line, they may become insulin dependent. Okay, so there's a strong correlation between metabolic syndrome and the development of non-insulin dependent diabetes. Metabolic syndrome, it's a syndrome, so it's just this constellation of symptoms that really increase the risk. So for diabetes, as well as other cardiovascular diseases like heart disease, vascular disease, and stroke. So the diagnosis of metabolic symptom requires you to hit three or more of the following. One is an abdominal obesity, which is referred to as visceral obesity, which is a waist circumference that measures greater than 35 inches in women or 40 inches in men. Blood pressure that's greater than 130/85, which is considered pre-hypertensive. Fasting blood sugar that's over 100. We've dropped that down. It used to be 110. We've dropped it down. I should say that really when you look at fasting blood sugar, you really want it to be no higher than 80 or 85. Anything higher than 80 or 85 really is showing you that you're having some issues with your glucose control when you're fasting, if you've been on a prolonged 12-hour fast. A really healthy blood sugar is somewhere between like 70 and 80, maybe even a little lower depending on the person. The diagnosis of diabetes isn't made until they're at 125. The diagnosis of metabolic syndrome, one of the criteria is a fasting blood glucose of 100 or over 100 or 100 even. High triglycerides, which is triglycerides that are equal to or greater than 150 milligrams per deciliter, and an HDL that's below 40 milligrams per deciliter in men and 50 in women. So they only have to have three of those. Three of those gets the diagnosis of metabolic syndrome, which then again increases your risk for diabetes, heart attacks, and strokes. You can see there was a study published in JAMA in 2015 that found that nearly 35% of the US population has metabolic syndrome, and 50% of the people over 60 years of age or older have metabolic syndrome. I think I read a statistic that said if we continue on the kind of trend that we are currently following, I think if I remember correctly, that by 2025, greater than 50% of adults in the United States will have diabetes, not just metabolic syndrome, but actually diabetes, non-insulin dependent diabetes. All right, so let's think about the treatment for a second, or let's talk about the role of insulin injections and then oral hypoglycemic agents. And then I want to talk a little bit about dietary control, exercise, and how to alleviate the symptoms of both type 1 and type 2 diabetes. Okay, so insulin-dependent diabetes, type 1. They require insulin injections. That's all I want you to really remember. They need insulin. There's all sorts of different types of insulin. There's short-acting, there's intermediate-acting, there's long-acting, and you can kind of see. So dosing insulin is kind of tricky, right? Insulin absorption is slowed by combining insulin with a protein such as NPH insulin, or combining insulin with zinc, or sometimes they do both. You don't need to remember this. You're going to get this someplace else. For now, all I want you to know is there's insulin. For insulin dependent or type 1 diabetics, they need insulin. I made you a chart that I think is on the next slide that you can have for your own personal reference. So it sounds easy, but it's actually pretty tricky because you have to be able to match the insulin dose with the need for the patient, depending on what's going on with their blood sugar. So what they're eating, their exercise level, their stress, all of that will change how much insulin they actually need. And so that's where the short acting, intermediate acting, long acting, right? They have to be able to be sustained while they're sleeping. So we don't think about this, but we're constantly secreting insulin and glucagon, keeping our blood sugar relatively stable. They can't do that. So we need to give them the insulin to do that. So you don't need to memorize this at all, but I wanted to just give it to you so you have an idea of what some of these names are, because you're going to get them in other places later on. So the rapid onset and short durations are these ones here. The intermediate onset and duration are here, and the prolonged duration are down here. So these are what so you'll hear like semi-lente, NPH, lente, ultra-lente. You'll hear that a lot in the field. And so I just wanted to kind of let you know what those terms mean, and you can again have this for your reference. But for our class, our purposes, what you want to remember is that insulin-dependent diabetics or type 1 need some form of insulin, or forms of insulin most appropriately. All right, with the non-insulin dependent, it's not quite that easy. So these people do produce insulin. Actually, if you're on it, you usually will see that their insulin levels are quite high early on. These are oftentimes overweight, more often than not adult, but this is changing. There's a lot more kids being diagnosed with non-insulin dependent diabetes. There are some people that are of normal weight and adult, but that's the minority of the people in this camp. And there are some that are prone to ketoacidosis, just like the type 1s, but there's not that many, only about 5% of them. So there's different ways to measure this. One is fasting glucose. The other is fasting insulin. The best way to kind of figure out how well they're controlled, although there are some caveats there, is a test called hemoglobin A1C, which is testing the glycosylated hemoglobin. If you've got a diabetic that has a hemoglobin A1C under 8, that's considered decent control. Really, we want our hemoglobin A1Cs like right around like 5 point. I think most labs consider 5.4 on the higher end of normal. So 8 is not good, but it's a diabetic, somebody who's got relatively decent control, you're going to expect that hemoglobin A1C to be pretty high. So these people with non-insulin dependent diabetes sometimes require insulin, but generally not first. Very definitely, this is a lifestyle disease, and dietary measures can be really helpful. Severely limiting the carbohydrates is the way to go with these patients, really limiting to almost very little carbohydrate. Exercise increases your muscles' sensitivity to insulin, and it helps your muscles to suck glucose out of the blood. So exercise and diet are huge for non-insulin dependent diabetes. Actually, you can totally reverse non-insulin dependent diabetes with a diet and exercise alone, but you've got to really be strict, right? There's no bagels in the world of the non-insulin dependent diabetics, right? They severely limit carbohydrates. They're most oftentimes going to be given an oral hypoglycemic agent. It's kind of interesting, there isn't really any data that shows that giving people oral hypoglycemic agents really do much at all for decreasing the complications and preventing these really disastrous side effects. If anything, it might just slow the whole thing down. So really where we want to focus is diet and exercise. I want to really hit this home because we are kind of, I think, a little bit inclined to believe that we can do whatever we want and then just take a medication to fix the issue. And this is not that situation. You are not going to reverse the signs of non-insulin dependent diabetes with an oral hypoglycemic agent, or insulin for that matter. It really has to be a lot more work. In many cases, it's very strict diet control and exercise and these oral agents, and they're still going to have some problems. So there's a lot of these drugs. These are the ones I'm going to introduce to you. The sulfonylureas, the alpha glucosidase inhibitors, the biguanides, and the TZDs, which I can never say that word because it's just got way too many letters, and especially vowels. It's really hard to say that, but TZD is what it gets abbreviated to. So I'm going to hit the highlights of these. I'm giving you way more information than you're going to need for your test, but I want to make sure that you've heard these. Your final homework is also going to be to read an article out of the medical letter, which is posted, which is all about these agents, and answer a few questions if you haven't already done so. So you'll get this in more detail in the article. So there's a bunch of different sulfonylureas. 30 brand names, 10 different drugs. You can see you're not responsible for knowing any of them by name. Some of them, if any of you work in the field, you've probably seen some of these agents. Some of them are short duration, some of them are long duration. Short duration and long duration just means they lower blood glucose for a short period of time or over a longer period of time, like an overnight fast. So how the sulfonylureas work in a nutshell is they stimulate the release of insulin. They reduce serum glucagon. They make your insulin receptors more sensitive to insulin. Remember, that's the problem with these people. It's an insulin receptor sensitivity issue. It is not that they don't have insulin. They have insulin, but the insulin isn't able to do its job because the insulin receptor loses its sensitivity. In order for the glucose to get transported into the cells, insulin has to bind the insulin receptor, and then that's what causes the GLUT transporter to be inserted into the cell wall. If you don't have insulin binding the insulin receptor, you don't get that glucose transport. The other thing that the sulfonylureas do is they seem to increase the liver's response to insulin, meaning we're better able to get the glucose actually out of the blood and stored as in the form of glycogen. The side effects for the sulfonylureas are not that major. There's some GI ones, maybe some rashes on the skin, potentially it's a little bit hard on the kidneys, and potentially might cause some blood disorders. But the biggest one and the most common one is hypoglycemia, and it can be pretty severe. So you got to make sure people are aware of that and they're well nourished and they're hydrated and all of that. And the other thing that's quite common with almost all the agents, which is kind of a bummer, is because these people tend to be overweight to begin with, but the sulfonylureas tend towards weight gain. All right, the alpha glucosidase inhibitors. So I gave you some examples, acarbose and meglitol. These oftentimes are nicknamed the starch blockers. So essentially what they do is they increase the time required for absorption of carbohydrates. So it takes longer to absorb carbohydrates, meaning you're not going to get such a glucose load in the blood. So they reduce serum glucose after eating. They don't seem to reduce serum glucose any other time. So these are oftentimes added on at mealtime if another agent has failed. So if they've been put on metformin, or which is a biguanide, we'll talk about that next, or if they've been put on a sulfonylureal, most people get started on metformin or biguanides, then they might add these things in for mealtime, but they don't seem to do much else other than right around the mealtime. They do seem to kind of potentiate the action additive with sulfonylureals, so if you're going to combine them, that's a good combination. The biggest problem with these, and if you think about it just for a second, you're just using common sense, if something is going to decrease the time required to absorb carbohydrates, meaning you're going to keep a lot more carbs in the tube, you can see that anytime you keep things in the tube that would normally be broken down and absorbed, that's going to cause some digestive distress. So usually greater than 70% of the users, they report pretty significant GI distress, diarrhea, bloating, gas, and it can be a rate limiting kind of a deal for those guys. So then we got the biguanides. So this, by far and away, metformin, or glucophage, which is a brand name of metformin, these are used the most common. They are almost always started. If someone's going to be started on an oral hypoglycemic agent, unless you have a compelling reason to do otherwise, you're probably going to start your patients on a biguanide. So monotherapy means that's the only drug they're taking. Oftentimes they'll also be used in combination, meaning that other drugs will be added after the biguanides aren't able to maintain blood glucose. And that does seem to happen. There does seem to be sort of a window, where they'll work for a while and then they're not able to maintain control. And so then something else would have to be added. They don't seem to cause as many hypoglycemic agents as we see with sulfonylureals, which is why we start with the biguanides. They also have a lower tendency for weight gain, maybe a little bit of weight gain, but not like the sulfonylureals. There's a different type of biguanide. The meglitinides are examples of a different type of biguanide. And these drugs decrease the glucose output from the liver and increase the peripheral utilization of glucose. So a little bit of a different kind of a mechanism here. Biguanides in general increase the receptor sensitivity, and they also increase the muscles sensitivity to insulin. Okay, so that's the one you want to remember. Biguanides, those are used a lot, metformin. Then we have the TZDs, the ones I can't say out loud, that word, because it's just too hard. Oftentimes because it's so hard to say, they refer to these as the glitazones. Avandia and Actos are examples. So these ones are interesting because they enhance the action of insulin at target tissues by acting as an agonist for a nuclear receptor called PPAR-gamma, or peroxisome proliferator activated receptor gamma. PPAR-gamma is a receptor that's expressed mainly in adipose tissue, and it regulates the production of protein involved in both glucose and lipid metabolism. So essentially what it's doing is it's sensitizing the liver, the muscle, the fat, and the liver to insulin. They seem pretty great for that reason, but there is pretty significant concern that they increase the risk of heart attacks, which is already a big issue with diabetics. So that's kind of a bummer. Then we've got the DPP4s. These are sort of newer, the DPP4 inhibitors. These are sort of newer drugs. DPP4 is called dipeptyl peptidase 4 inhibitor. So DPP4 is responsible for activating and breaking down 2 GI hormones that are responsible for lowering serum glucose production, or I should say that lower serum glucose production. The 2 hormones that they inactivate are GLP-1, or glucagon-like peptide 1, and a glucose-dependent insulinotropic peptide, which is called the GIP. So these drugs, the DPP4s, inhibit both GLP-1 and GIP. So what these hormones do is they potentiate the insulin synthesis and the release of they potentiate the release by the beta cells of the pancreas, and they decrease glucagon production by alpha cells. So essentially what they do is they prolong the action of the gut-derived factors that potentiate insulin secretion after a meal. So, and they do that by inhibiting that enzyme. That enzyme would normally break down those peptides, but by inhibiting them, they potentiate the action of insulin and decrease the glucagon production. So that's kind of great. And then finally, there's these 3 other drugs called EXANATIDE, LIRAGLUTIDE, and PRAMLINTIDE. These are kind of newer drugs, and they're peptides, and they're similar to a hormone. They're similar to the hormone called GLP-1, the one we just talked about. So essentially what they do is, in the presence of glucose, they act to stimulate more insulin secretion. So they help us make more insulin. So you have to have beta cells that are capable of making insulin to do this. There's more to this. Obviously, I really kind of broke it down to the bare minimum, but that's what I want you to know. So now that you know that, I would like you to read that article, which will cement some of that stuff and answer those questions. So I will catch up with you guys later. The next video is going to be looking at some hormones, estrogen, progesterone, and testosterone. See you then.